So today we'll be discussing about the vitreous hemorrhage. If you want, you can view the video in 1.5x or more, whatever is comfortable to you. So any blood in the vitreous cavity, we define it as vitreous hemorrhage. How do you properly define it? Presence of extravasated blood within a space lined by. So you are describing the vitreous cavity. So basically, anteriormost wall of the vitreous cavity will be found by the lens. Properly, the posterior lens capsule. So this will be your posterior lens capsule, which will form the anteriormost wall of the vitreous cavity. The posterior wall of the vitreous cavity is formed by retina. What is the anteriormost layer of retina? That is the internal limiting membrane. So internal limiting membrane will form the posterior wall of the vitreous cavity. Then you will have the laterally the non-pigmented epithelium of the ciliary body. Inside the vitreous cavity, we'll have the vitreous gel. This is your vitreous gel. So any bleeding occurring in this vitreous gel, we call it as vitreous hemorrhage. So classification of vitreous hemorrhage, we classify vitreous hemorrhage into either pre-retinal vitreous hemorrhage or intraocular hemorrhage. So what is pre-retinal vitreous hemorrhage? So basically you have the retina. In front of the retina you have the vitreous. Again you have the retina, and in front of the retina you have the vitreous. So if any bleeding is occurring in this particular area, just in front of the retina, you call it as pre-retinal hemorrhage. If any bleeding is occurring inside the gel, vitreous gel proper, you call it as intraocular hemorrhage. And then again, based on the location involved, whether it is anterior part of vitreous gel is involved, middle part or posterior part, we divide it into anterior vitreous hemorrhage, middle vitreous hemorrhage, and posterior vitreous hemorrhage. If whole of the vitreous cavity is involved, you call it as whole or total vitreous hemorrhage. Next, so coming to the etiology, the three most common causes include, most important, proliferative diabetic retinopathy, posterior vitreous detachment with or without retinal tear, ocular trauma, which includes close and open. Both globe injuries are involved in vitreous hemorrhage. Other causes. What are the other causes of vitreous hemorrhage? They include vascular disorders. Example, retinal vein occlusion, retinal vasculitis, and retinal arterial microaneurysm. These microaneurysms also rupture, and that gives vitreous hemorrhage. And any inflammatory disorders. Inflammatory disorders, they cause erosion of the blood vessels. For example, you got acute chorioretinitis, uveitis, and Ehlers disease. So these are the main inflammatory disorders which cause vitreous hemorrhage. Next is your metabolic disorders. The most common metabolic disorder is your DM retinopathy. Blood dyscrasias. These blood dyscrasias, they cause hypoxia sometimes, and they cause neovascularization. Because of that, the new vessels will be bleeding into the vitreous cavity. Example, retinopathy of anemia, sickle cell retinopathy. And some bleeding disorders. Obviously, the patient with bleeding disorders will have predisposition to form petechiae, hemorrhages, lot of bleeding dyscrasias, right? Example, hemophilia and scurvy, vitamin C deficiency. And neoplasms. Neoplasms will also have neovascularization. So rupture of the vessels, and then you'll have acute necrosis. Because of that, you'll have vitreous hemorrhage. So retinoblastoma, malignant melanoma of choroid. Retina and choroid are the most commonly involved tumors. Next, some other causes which includes like Terson syndrome and Coats disease. You can remember the names. So these are the main etiological factors. Mainly we need to remember proliferative diabetic retinopathy, posterior vitreous detachment with or without retinal tear, and ocular trauma. These are the main important etiological factors. Coming to the clinical features. Clinical features, history or symptoms. The patient will be complaining of new onset floaters, shadows or cobwebs. The patient will typically give a history of something is floating in front of his eyes, which is little bit opaque. And then sudden painless loss of vision. Painless loss of vision. So pain will not be there. The patient may either have a vision loss or blurring of vision, like haziness. Then because bleeding is there in the vitreous cavity, the patient may have reddish hue in the vision. And then it worsens in the morning. Why does it worsen in the morning? So you have the retina. While you are sleeping, retina will be downwards, right? And you'll have the macula. Think of this as the macula. the blood will settle on the macula. So the entire macula will be covered with blood. So you will not be able to see once you wake up immediately after morning. So worsening in the morning will be there. Next, coming to the ocular examination proper. You examine first for visual acuity. It is variable, depends upon the location of the hemorrhage, size of the hemorrhage, and degree of the hemorrhage. Visual field will be defective. You will have scotomas based on the locations of the hemorrhage. If macula is involved, major visual field defects will be there. Then you examine for iris. You need to check for iris rubeosis. Any neovascularization of iris is there. That indicates chronic vitreous hemorrhage. Then, using digital tonometry or some applanation or indentation tonometry, whatever tonometry you use, we measure intraocular pressure. It is either normal or increased. If it is increased, you need to do gonioscopy to rule out whether there is any neovascularization of angle, because intraocular pressure is increased, obviously you will have some glaucoma pathology will be developing in the patient because of this vitreous hemorrhage. Then you do slit lamp examination, you will see red cells in the anterior vitreous. This is the ocular examination proper. Then the most important part is your dilated fundus examination. Dilated fundus examination, you give atropine drops to the patient and you wait for some time and you examine the patient. So direct distant ophthalmoscopy. If you do a direct distant ophthalmoscopy, in case of small hemorrhages, you will see black shadows against the proper red glow. Black shadows against the proper red glow. You get a red reflex, right? In the red reflex, you'll get the black shadows. Simple as that. Then large hemorrhages, you will not see the red reflex at all. No red glow at all. Next is your direct and indirect ophthalmoscopy. You come closer to the patient's eye, you use the hand lens and you view it, right? Small hemorrhages. If the patient is having small hemorrhages, you will see blood that might be diffusely spread or localized to some parts of the vitreous, as in anterior, middle, posterior vitreous hemorrhage. If you are having a large vitreous hemorrhage, then you will have the retinal view will be completely obscured. You will not be able to view the retina at all. Then you have something called subhyaloid hemorrhage. What is subhyaloid hemorrhage? It is the pre-retinal hemorrhage. In that case, you will have scaphoid or boat-shaped hemorrhage. Basically, the blood settles down. You will have the detachment of the vitreous. So, if you think of this as your retina, and on the top of it, you have the detached vitreous. Okay, let's take this. So, you have the detached vitreous. So, if you view through the ophthalmoscope, you will have blood settled in this manner, giving rise to scaphoid or boat shaped. This is specially seen in cases of subhyaloid or pre-retinal hemorrhages. And then you may have a pathology of detached posterior hyaloid. So posterior vitreous detachment, you have the hyaloid phase. Hyaloid phase is your, so you have the vitreous. So think of the vitreous has been this vitreous has been detached, and then you have the retina. So this particular phase is called the posterior phase. That is the hyaloid phase, will have blood adherent to it. Okay. Next is your chronic hemorrhage. Chronic hemorrhage, the hemorrhage has already occurred and so much of time has already passed. So what happens? The blood cells, they will die. They become dehemoglobinized. And based upon the duration, it is either khaki or yellow or white in color. And most important point of all this is you will locate the source of hemorrhage, whether there is any neovascularization which is giving rise to hemorrhage, or any old vessel which is bleeding, or any retinitis is there, or any injury is there. That and all you can rule out using this dilated fundus examination. So citing the source of hemorrhage is very important. Next is your evaluate the associations. You need to evaluate the association using scleral indentation. You indent the sclera using the indenter and you evaluate. Mostly you need to evaluate for the acute PVD, posterior vitreous detachment, retinal tear or retinal detachment. These are the associations. Then you will do fellow eye examination. Why do you do fellow eye examination? Basically you want to rule out the any relevant etiology is there or not. Any relevant etiology, that is most important, no? Because in case of diabetic retinopathy associated vitreous hemorrhage, you will see similar fundus changes in both left eye as well as right eye, both affected eye as well as the normal eye. Normal in the case, it has that diabetic retinopathy pathology. Coming to the diagnostic procedures. Most important one is the B scan USG. What are the indications of B scan USG? Vitreous hemorrhage, which obscures the complete view of retina. That is your large vitreous hemorrhage. So what does this detect? Vitreous hemorrhage it detects, posterior vitreous detachment it detects, retinal tears, retinal detachment, any tractional membranes on retina that also it detects, intraocular tumors and foreign bodies. Everything will be detected by the B scan USG. Then you do something called fluorescence angiography. What are the indications of this? Mild to moderate vitreous hemorrhages. What does it detect? Neovascularization. Simple as that. Then orbital CT scan. You have something called orbital CT scan. It is indicated only in the cases of globe injury, open globe injury. So in open globe injury, what happens is the eyeball gets crushed. So you need to check for the integrity of the posterior eyeball and to see any intraocular foreign body is there or not. So for that you do orbital CT. Then coming to other system examinations and lab investigation to rule out the systemic diseases. Simple. Diabetes, you do blood glucose, fasting, postprandial, HbA1c and so on. Coming to the management. Conservative management or the general management, what do you advise the patient? We ask the patient to minimize any strenuous activity, keep the head end elevated, bilateral patching and bed rest. All these are to reduce further bleeding or any recurrence. Simple, right? Self-explanatory. Coming to the surgical or general management. So you are able to view the retina and the etiology is also established. Okay, based on that. If you are able to view the retina and etiology is established, you see whether it is safe or not safe. If it is safe, you gradually treat the etiology, the vitreous hemorrhage will get solved by itself. If it is not safe, you go with PPV. What is PPV? Pars plana vitrectomy. Pars plana vitrectomy. Okay. Then you observe. Now you observe for any associated retinal tears are there or not. So mostly the retinal tears will be there. If the retinal tears are there, you see whether the posterior margin is approachable or not approachable. If posterior margin is approachable, immediately you can do endo laser. But endo laser cannot penetrate up to the posterior margins, posterior part of the retina, right? In that case, you use red laser. Some surgeons, they also use cryotherapy, alternative way. If you did not view the retina and you did not establish the etiology, you can do promptly pars plana vitrectomy and you observe. If you are having any neovascularization changes, either in retina or in iris or in angles, gonioscopy you'll do and you'll rule out, no? You need to treat those also because that will lead to further complications. If you don't treat the angle thing, no, it will lead to glaucoma. Acute attacks will be precipitated. So you need to be careful of that also. Next, coming to the surgical management in patient with diabetes. For example, if a patient is having diabetes, how do you manage? The patient with diabetes, you examine the fellow eye for similar changes. Okay. If the changes are not seen, okay, this is fine. Okay, the vitreous hemorrhage is probably not due to diabetes. If the changes are seen, it might be due to diabetes. Then you examine for proliferative diabetic retinopathy and then whether you have adequate view of retina and then whether have you seen for proliferative diabetic retinopathy, whether the patient had history of pan-retinal photocoagulation. Based on that, if the patient did not have any of these, then you do pars plana vitrectomy and then intraoperative you can do pan-retinal photocoagulation. Or else you can give intravitreal anti-VEGF injections to the patient. Simple. Okay. Simple. You need to retinal view is the first thing. If you are able to view the retina, whether proliferative diabetic retinopathy is there or not, history of pan-retinal photocoagulation is there or not. If it is not there, you come with pars plana vitrectomy. Following that, you can give intraoperative pan-retinal photocoagulation or intraoperative or intravitreal anti-VEGF injections. Now check for hemorrhage clearance in 1 month. Yes it is resolved. No, again you do pars plana vitrectomy. You remove some more amount of vitreous. Okay, the patient has proliferative diabetic retinopathy and he also has history of panretinal photocoagulation. Yes. Whether it is new hemorrhage or recurrent hemorrhage, mostly secondary to DMR. DMR is diabetic retinopathy. Observe for 3 to 6 months. You keep observing the patient and then you consider pars plana vitrectomy. Directly don't go for pars plana vitrectomy in this particular patient. So coming to the medical management, anti-VEGF injections are given. What are the most common anti-VEGF injections given? Bevacizumab, ranibizumab, aflibercept. These are the main anti-VEGF injections given routinely as a part of diabetes treatment protocol, as well as sometimes when you are doing PPV, pars plana vitrectomy, pre-oply 1 to 7 days before the surgery also you give intravitreous anti-VEGF injections. They are mostly indicated in the proliferative diabetic retinopathy. The prognosis of the patients is variable. It depends upon the etiology, what are the causing factors, status of the optic nerve. If optic nerve is gone, blindness, complete blindness, eye cannot be restored. Macular involvement. If macula is involved, more vision loss will be there. For example, patients with vitreous hemorrhage secondary to PDR, proliferative diabetic retinopathy, or age-related macular degeneration will have more guarded prognosis. So they have proper etiology established and status of optic nerve and macular involvement will also be there. So they will have more guarded prognosis. Guarded prognosis means you can't know, you can't say. So it is question mark. Than those with vitreous hemorrhage resulting from posterior vitreous detachment, that you can have some positive prognosis as compared to these patients. Mostly this vitreous hemorrhage is easily solvable thing, easily curable thing, but comparatively diabetic patients and age-related macular degeneration parents will have more guarded prognosis. Thank you so much.